Can you guys hear me? Cool. Well, good morning. Happy last class and poison management trophies. What day does your guys' exam start? Monday? Yeah. Oh, you got a week then. Yeah. Right? Today's Tuesday?
6 days.
6 days. Yeah, I was just telling Dr. Friend here that this is my favorite time of year because I would just kind of hang out for like 4 days and then study like 2 days before the exams. Right? Nothing's cumulative, right?
It's unbelievable.
So it's just exams. It's not even like final exams. It's like easier than a regular semester exam because you don't have class, right? Nothing's cumulative. The exams are reasonable intervals. You have 5 exams a week during the semester anyway, right? So it's just another exam week without class. So it's easier, right? So relatively speaking. I'm not saying it's easy, I'm just saying it's relatively easier. In any event, so this is Dr. Kimberly Friend. She is currently the PGY2 EM pharmacy resident with myself at Robert Wood Johnson Hospital, University Hospital. She's going to talk about lithium and sedatives, and then she's going to talk about, what was it again?
Flocka.
What?
This isn't a video on Flocka.
Flocka, like Waka Flocka? Waka Flocka plane, right? Anyway, she's going to talk about that. So here she is.
Thank you.
Excuse me.
Thank you. All right, can you guys hear me? All right, so in honor of Dr. Bridgman, who wants to do something new and interesting at the beginning of class, I have a video on a drug named Flocka that's actually been out since the end of 2015, but it recently hit my hometown, and a lot of people have contacted me to see if I'm seeing it up here in New Jersey. I'm from Georgia, so it originated down in Florida, and this is just like a 3-minute video kind of explaining to you guys about this new designer drug.
Kentucky, California, and Florida, especially hard. Mark Albert is in Washington with a look at the new threat that's alarming the police and the doctors too. Mark, good morning.
Good morning. It's a drug that is described as being more powerful than heroin or cocaine. And medical experts and law enforcement are warning of the dangers not just to users, but to anyone who gets in their way. These videos show what can happen when Flocka takes over. Psychotic breakdowns, hallucinations, and indiscriminate violence. Last month, an 82-year-old great-grandmother died weeks after being randomly attacked in her Riviera Beach, Florida home by a man who police say was high on Flocka. This man impaled himself on a fence at the Fort Lauderdale police station while on the drug. Mike Haney, who lives near Chicago, says he doesn't remember what he did for 2 days after unwittingly taking Flocka.
I was completely out of my mind. I could have killed somebody, I could have killed myself.
Flocka, also known as gravel, is a synthetic stimulant, a cousin of the drug found in bath salts. It's an ever-changing mixture of various substances and can come in a capsule or powder. Users can smoke, swallow, or inject the drug. Florida is now the epicenter of the outbreak, with 25 Flocka-related deaths in South Florida's Broward County in the past 10 months alone. Special Agent Kevin Stanville in Miami is leading the DEA's Flocka fight.
We have individuals high on Flocka that are coming up to parents with their kids, trying to take the kids. They're not only just getting high, they're going out there hurting other people. You don't see that with a lot of the other drugs like you are with Flocka right now.
Stanville says Flocka is often imported from China. It's up to 10 times cheaper than the synthetic drug cocktail Molly, just $3 to $5 per hit, and easier to get. They can be ordered online and delivered to your door.
I feel for those officers that are going to be out on patrol and they roll up on somebody and they are on Flocka and they have that superhuman screen. Or it takes 6 policemen to hold them down. That's a problem.
Brad Lamb is an addiction interventionist in Los Angeles. His practice had no Flocka patients just 8 weeks ago. Now, they've had a dozen people calling for help.
The drug takes away all the inhibitions and also erases the body's ability to tamp down on dopamine and serotonin. So you just feel like you can do anything. I think that we're going to see waves of this that are going to be very, very devastating.
Lamb says even proactive parents who give their teens urine tests after suspecting drug use are stunned. Those who make Flocka are constantly changing its makeup so as to fool common tests.
The old reliable drug test that you get at the corner store will not show positive for this drug. They're not even able to test for it yet. It's just not included. It's ahead of the curve.
Lamb told us patients on this drug take several weeks or longer to recover than those on meth. Now, often the key ingredient in Flocka is known as alpha PDP. The DEA's Miami division told us in just the first 6 months of this year, it seized 3.5 times the amount of alpha PDP that it seized in all of last year. Okay. Well, Mark, thank you very much.
All right, cool. So Flocka is like $3 apparently. When I was in high school, it was Molly that people bought, and now it's apparently Flocka. And the high that they get lasts a couple of hours and then is gone, and most of the time they don't remember actually what's happening. So I just thought that was interesting to start with. But today we're going to be talking about lithium and sedative hypnotics. They're kind of two completely separate entities, so I've set up the PowerPoints to reflect that. I don't want you thinking that they are in any way intertwined or related in terms of management, okay? So at the end of the hour, I hope that you guys can identify signs and symptoms of both lithium toxicity as well as patients who present with a sedative hypnotic overdose, and you are able to formulate and design a treatment plan and appropriately manage these patients as such. So I've sat through a couple of these classes, and I thought I would answer the question before it started. Yes, you do have to know doses. There's literally one drug in here that I want you to know the dose for, okay? You're going to be pharmacists soon, and I think it's important. So I think that it's fair, and I'm telling you ahead of time. So to get started, I kind of want to tell you how I think about lithium, and you don't have to think about it this way, but it kind of helps me come full circle. So when somebody says lithium, I automatically start thinking about batteries. And then for some reason, I think about somebody touching something electric and looking like this. And then this man reminds me of Mr. Hyde from Dr. Jekyll and Mr. Hyde. And Dr. Jekyll and Mr. Hyde was bipolar with multiple personality, and the treatment for bipolar disorder is lithium. So now that we've come full circle, I want you guys to understand why lithium toxicity should be on your radar. I just told you that lithium is the standard of care for patients with acute mania and bipolar disorder. And bipolar disorder affects up to 2% of the adult population. So while that doesn't seem like a large number, I'm talking about hundreds of thousands of people, okay? Now, these patients, or these people with a diagnosis of bipolar disorder, have a 25% suicide rate, and that's a successful suicide attempt. And the most common way for them to do this is via their own medication. These patients are typically your non-compliant, non-adherent patients, and that's because they have bipolar disorder, right? Bipolar disorder, whether it's bipolar 1 or bipolar 2, you're cycling through episodes of mania or hypomania, and then into episodes of depression. And when these patients are manic or hypomanic, they feel really good. They don't feel sick. They don't feel like they have anything wrong with them. It would be like you guys popping an Adderall and studying for a test, right? You don't feel sick. You feel like you can get a lot done. You feel, like you can conquer the world. You might not have these weird sort of gambling tendencies or weird sexual behavior like patients who have a diagnosis of bipolar disorder, but you don't feel sick. So during these episodes of mania or hypomania, a lot of these patients are not taking their medication. They may be filling it regularly, and they may be acquiring hundreds of tablets of lithium, but they're not taking it. And then they have a depressive episode, and the depressive episode is where they start to feel sick, and now they look and they have access to 270 tablets of lithium, and this seems like an easy, quick way to, try to attempt suicide. So we got to get into the nitty-gritty a little bit about the PK of lithium. I know this is really boring, but it's important. So we'll talk a little bit about the absorption, distribution, metabolism, and elimination. We'll start with the absorption. So it's rapid absorption from the GI tract, and the time to peak is anywhere from 20 minutes to 5 hours. Lithium itself has a really low volume of distribution, which we will talk about later when we start talking about management, and the half-life is 24 hours. Now, half-life is a commonly confusing topic for pharmacy students. I see it all the time. I struggled with it myself. I see it with my students on rotation. So if you have a half-life of 24 hours, it takes 4 to 5 half-lives to get to steady state. So this drug is sitting in your system. It's getting to steady state in 4 to 5 days. Yet we dose lithium multiple times daily, even with a half-life of 24 hours, which is weird, right? We look at other drugs that have a half-life of 24 hours and we give it to them once a day, not 3 times daily. And that's because lithium is sort of limited in its dosing by its side effects. The patients get a lot of GI upset, nausea. So we reduce the dose and we spread it out over the course of the day. It has no active metabolites and it's mostly renally eliminated. So we have a long time to get to steady state, a couple of days, renal elimination. So you need to think about that when you have patients who have any type of renal dysfunction. And also it comes in multiple dosage forms, which gets really important when we talk about management. Now, I'm not only talking about tablets, capsules, liquids, I'm talking about different release products. So your sustained release, your extended release versus just your immediate release. All right. So lithium resembles sodium in our bodies. It's handled like sodium in our kidneys. So it's freely filtered, it's freely reabsorbed. You can think about it like anything that affects our renal function or our sodium balance can alter lithium levels. Now I'll go through each of these because I think they're important, and honestly I had kind of a difficult time myself understanding them, and I think if you think about the pathophysiology and why things are changing within our body and how the sodium balance is changing, then you can have sort of a better understanding. Now I mentioned it's mostly renally eliminated, so if patients have problems with renal elimination or any type of impairment to their kidneys, you can understand why you'd have an increase in your lithium levels, right? They're not excreting the lithium as they should. They're not excreting the sodium as they should. This goes sort of hand in hand with heart failure. Heart failure patients have renal dysfunction because of their underlying diagnosis of heart failure. They're retaining fluids, they're retaining sodium, they're retaining their lithium. This also works with dehydration, which is kind of counterintuitive because you think about heart failure patients and you say, well, they're retaining fluid and they have increases in lithium, but if you're dehydrated, you're dry, how is this happening? So when you think about the process of dehydration, your body starts to concentrate its electrolytes, right? You're losing water, but you're retaining your sodium, you're retaining your lithium, and this is why you start to see increases in your lithium levels. And then ACEs and ARBs was really difficult for me to understand because ACEs and ARBs, when we think about them, we think that they cause hyponatremia. And I just told you that lithium follows sodium in the body, so if they cause hyponatremia, when they cause low levels of lithium. So I looked into this and I found these proposed mechanisms that were very complex, and I was going to share them with you, but then I just talked to a toxicologist that we have on hand yesterday actually, and she said, I think about it like you're used to having this tank, and the ACEs and the ARBs, they affect your afferent arterioles in your renal system. And if you're constricting those afferent arterioles, you're essentially maintaining and retaining your sodium and your lithium levels, which cause increases in lithium. There have been several studies in American Journal of Psychiatry that look at healthy patients who are they put on lithium, and then they add an ACE or an ARB, and they've seen up to 35% increase in lithium levels, and they've seen up to 25% decrease in lithium elimination. And this becomes really important because lithium, as we're going to get to soon, is a narrow therapeutic index drug. So this is something we need to keep in mind. If you have an increased sodium intake, lithium sort of starts to compete with your sodium. So we try to get rid of the sodium, and in turn we get rid of the lithium as well, which is why you'll have decreased lithium levels there. So knowing as a pharmacist, a patient comes in, they're getting their lithium filled, and then all of a sudden they get something new tacked on the next month, these are interactions that you're going to need to start thinking about, right? What are some other precautions we need to think about with lithium? So lithium is a pregnancy category D drug, and I know we're moving away from the pregnancy categories, but a pregnancy category D means that there is positive evidence of issues with the fetus, or there has been studies done in animals or things that have come up with actual pregnant women showing problems with the fetus. So this is a risk benefit that we're going to have to think about. You have a patient that comes to the counter and they're pregnant and they're on their lithium, this is a conversation that you need to have with them and they need to have with their provider. Lithium also inhibits the actions of iodine. So it sort of congregates in your thyroid tissue by active transport and essentially outcompetes iodine from being reabsorbed and can cause hypothyroidism in up to 70% of your patients. It's mostly women, but it's really important to know that this is a side effect of the medication. Lithium can cause leukocytosis, which is an effect on our white blood cell count, and this happens in almost 100% of our patients. And it can cause diabetes insipidus. And when I'm referring to diabetes insipidus, I'm mostly referring to nephrogenic diabetes insipidus, and that's because lithium enters your tubules because we have sodium and lithium channels on our distal convoluted tubules. And it increases our sodium excretion and it decreases our responsiveness to aldosterone. And on top of all these disease state precautions that you have to keep in mind, like I mentioned a few minutes ago, it's imperative that you understand lithium is a narrow therapeutic index drug. It's not like valproic acid where a therapeutic level is between 50 and 100. A therapeutic level here is between 0.6 and 1.2 if you're talking about maintenance therapy. So less than 1 and all of a sudden you're at a toxic level. So a therapeutic index, a narrow therapeutic index drug means that the therapeutic dose is very close to the toxic dose. And we're talking about toxicology today, and this is what we're going to get into. Also, for completion's sake, I'm not going to test you on this. There is a syndrome, it's referred to as SILENT, the syndrome of irreversible lithium effectuated neurotoxicity. And essentially, this is caused by lithium in the absence of any prior neurological dysfunction. Treatment of lithium toxicity may or may not prevent this, and it can persist even after you stop taking the medication. The proposed mechanism is really unknown. They think it has to do with demyelination and possible cellular loss. Again, I'm not testing you on this. I just wanted it there for completion's sake. All right, so now that we've belabored the pharmacokinetics and the precautions of lithium, I want to talk to you guys about the different types of toxicity because this is really important, particularly when you need to manage these patients in the emergency department. There's 3 types of toxicity. We will start with acute toxicity. This is when you have a patient who is not taking lithium and then all of a sudden takes a bunch of lithium. This can be your patient who has a diagnosis of bipolar disorder and has been manic for a couple weeks and not taking their medications. This can be your patient who is newly diagnosed and they go to the pharmacy and they get their 600 milligrams TID of lithium and they just take a bunch in one setting. Versus your chronic toxicity patients, who are patients who are on lithium and they're taking it like they're supposed to be taking it. They are doing nothing wrong, they're taking it as prescribed, and for some reason, whether they have an underlying renal dysfunction that they're unaware of, maybe they've tacked on another medication like an NSAID or an ACE or an ARB, their levels are just higher than what they should be. And then lastly, we have our acute on chronic toxicity, where you have your patient who is taking their lithium as prescribed and has underlying increasing levels that they're unaware of, and then takes a bunch more lithium. Does that make sense? All right, cool. So how does this present as a laboratory value? Well, I told you that the lithium steady state takes a really long time. The half-life is 24 hours. So when you take a bunch of lithium in one setting, it sits around in your blood and your plasma. It's peripherally in your serum. It's not crossing over into your blood-brain barrier yet because it's not at steady state. So when these patients come in and they've acutely ingested a bunch of lithium, it's all floating around in their periphery. And when you take a level, it's really high. But they may not be exhibiting signs and symptoms of toxicity because it's not yet in their brain. It's just all in their blood. Versus your chronic patient who's taking it as prescribed, doing nothing wrong, has had plenty of time for lithium to get to steady state. It's all in their brain. They're acting very confused. They have signs and symptoms of toxicity, but when you pull a level, it's normal or low even because it's had time to get to that steady state concentration. And then lastly, you have your acute on chronic, where they've already accumulated it in their central nervous system. They're exhibiting signs and symptoms of toxicity because it's all in their brain, but then they've also ingested a bunch acutely, so it's floating around in their blood, so your levels are high. Does that make sense? I want you guys to understand that the levels don't always correspond with the signs and symptoms that these patients are presenting with. So how are these patients presenting? All right, I have a bunch of words here on the left hand, or on the right hand side, excuse me, that pretty much all mean the same thing. These patients come in and they have tremor, they have fasciculations, they have chorea, which is a fancy way of saying like jerky movements, usually in their face. They have ataxia, which is loss of bodily movement control. Clonus, muscle spasms. Usually the clonus for some reason is more so in their lower extremities and their upper extremities. Yes?
I'm sorry, can you, on the last slide, can you go ahead and explain the acute on chronic?
Sure. So acute on chronic, the levels or just in general?
In general, you said it accumulates in the CNS and in the environment.
Right. So if you are taking lithium chronically, and lithium has a long time to steady state because its half-life is 24 hours. It starts to accumulate in your CNS, and this can be for any particular reason. As I mentioned, you might have underlying renal dysfunction, you might have a dose that's just a little bit too high for you, you're not clearing it adequately, or maybe you added on a medication that's increasing your levels and increasing your lithium retention. So it's starting to build up. And it's getting in your, it's in your CNS, and you're starting to have sort of altered mental status, maybe some tremors, and then additionally you take a bunch of lithium. Like you just had a bunch lying around, you're in a depressed state, you're taking it as prescribed, but now I'm just going to take 30 more because they're here and I'm depressed. So you've already started to accumulate it chronically, and then you've acutely ingested some more. So your levels, you'll have high levels in the CNS as well as high levels peripherally because of that acute ingestion on top of the chronic ingestion. All right, so just sort of a bunch of things that mean the same thing. Clonus, a little bit more in your lower extremities than your upper extremities, altered mental status, agitation, and then of course the trifecta that goes on every commercial, seizure, coma, death, that has to be there, right? This is what we want to prevent when these patients come in. So how do we diagnose this? I mentioned when we were talking a little bit about acute, chronic, and acute on chronic, that we can get a serum lithium level, excuse me. This seems like the most obvious thing, right? However, if you have a chronic ingestion and you get a serum lithium level and it's normal, what else can you do? You say, okay, I know their history, they take lithium, this looks like lithium toxicity, but I can't prove it because my serum level shows that they have a therapeutic level. What else can we look for? Now, when I was talking about lithium precautions, I mentioned that lithium can cause leukocytosis. So getting a CBC is important, right? What's on a CBC? It's the X that you see, right? You have the hemoglobin and hematocrit, you have your white count and your platelets. So here we would be looking specifically at their white count because we know that lithium can cause leukocytosis in 70% of our patients. We also would check for a BMP. What's on a BMP? Or you guys probably are more familiar with the Chem 7 panel. It's our electrolytes, right? Our sodium, our potassium. If our patient comes in and they're altered, and all of a sudden you see that, oh, well, they're hyponatremic at 112. Maybe they're just hyponatremic. Maybe it's not lithium. This is sort of a rule out. Is this lithium? Is this not? We want to look at a thyroid function test. I mentioned on the precaution slide that lithium outcompetes iodine in the thyroid gland. It can cause hypothyroidism. Is this patient altered because they're hypothyroid, or is this patient altered because they've had an ingestion of lithium? And then we have sort of our concomitant labs that we always send when we have an idea that this may be a toxic ingestion, and that's our alcohol, our ETOH, our aspirin or our salicylates, and our acetaminophen, because we know how to treat those. And commonly when patients overdose on things, they overdose on more than one type of tablet, and they may not know what's in it. So to miss a salicylate or an acetaminophen overdose would be really faux pas and might haunt you for a long time. So we send all of these levels out to see if we are treating the right thing. Okay. So toxicology. While I said, especially in your chronic patients, you might see symptoms of toxicity even at therapeutic levels, this is sort of a guide to what type of symptoms you can expect to see in your patients, dependent on what your serum lithium level is when you pull it. So less than 1.5, remember a therapeutic level is 0.6 to 1.2. This is just above a therapeutic level. This is just toxic. You can start to see a fine tremor, nausea, muscle weakness, versus 1.5 to 2.5, now we're 2 times the therapeutic level. You're seeing more of a coarse tremor and confusion. And then greater than 2.5 is where you get your dreaded seizure, coma, death. And this is a guide. This is what you can expect to see. And again, please remember that you can see these manifestations of toxicity even at normal therapeutic levels. Yes? These symptoms are for any type of ingestion. You could. Mm-hmm. So if you have a chronic ingestion, you may have low, normal, or high levels. We can't say that because somebody has signs and symptoms or is not presenting the signs and symptoms of toxicity that they are a chronic versus an acute versus an acute on chronic ingestion. We can expect more so to see that a chronic ingestion on somebody who we're not sure why they're retaining a little bit more lithium than normal could be a normal level and they could have altered mental status. But it's not always the case. Does that make sense? Okay. All right, so now that we've talked about the PK, we've talked about signs and symptoms, let's talk about how to manage these patients. All right, so the first thing that we want to do, and it's not necessarily us as pharmacists, it's more so the entire team, is we want to look at their airway, their breathing, and their circulation. This is always going to be the first thing that we do. And then we start thinking about IV fluids for these patients. And then we entertain the idea of GI contamination versus whole bowel irrigation, which we'll get to, and you'll see that GI contamination actually plays no role in the management for these patients. And then last line is going to be our hemodialysis. So after the team has established the airway and the breathing and the circulation, we start thinking about fluids and resuscitation for this patient. So which fluids are we thinking about? How much fluid are we thinking about? And really, why are we giving these patients fluids? Now, it's critical that we restore the intravascular volume. Most of these patients have volume responsive decreases in their renal function, and this is why they are retaining their lithium levels. We know that renal dysfunction has a positive association with acute toxicity or any type of toxicity, so we want to manage this. And our fluid of choice is normal saline. Now, normal saline is 0.9% sodium chloride, right? So you might say, well, why are we giving these patients sodium? You just told me that lithium follows sodium. We're doing it sort of to outcompete, right? If we give them enough sodium, they might retain a little bit more sodium than they're retaining lithium. And we can restore their intravascular space. We can restore their renal function. Then they can start excreting this lithium and this additional sodium and eventually get more of a normal level. Now, how do we dose this? So we're going to give these patients a bolus. That's a given. We give them 20 mLs per kilo as a bolus. And then we try to figure out what their maintenance rate is. And a maintenance rate is calculated via what's called a 4-2-1 method. And this was actually started in pediatric patients. You won't hear people referring to it as a 4-2-1 method in your adult patients, but this is really how they get the number for how many mLs an hour they want to run their fluids. So if you are somewhere between 0 and 10 kilos, we're going to start giving you 4 mLs per kilo per hour. So if you are 10 kilos, how many mLs an hour are you going to get? 40, right? So that's the 4 in the 4-2-1 method. And then if you're somewhere above 10 kilos, from anywhere from 10 to 20 kilos, we give you an additional 2 mLs an hour. So if you are 20 kilos, how many mLs an hour is your maintenance fluid? What's that? 60, right? 40 plus the 2 mLs for each 10 kilos you are from 10 to 20, 60. And then for every kilo you are above 20, we give you 1, the 4-2-1 method, 1 mL per kilo per hour. All right, so I'm going to let you guys try this one. I've got a 70 kilo patient. Let's say we give them the bolus already at 20 cc's per kilo. What do we think the maintenance IV rate is for this man? Bless you. Any takers? I'm not judging you. But if I were you, I would learn how to do this for testing purposes. Yes.
70 ml.
How did you calculate that?
He was on 20 kilograms and
So we still have to do the 4 and the 2 portion of him. So he's gonna, for the first 10 kilos this man weighs, he's gonna get 40. Then for the next 10, he's gonna get 20. So for every kilo essentially above 20, you're gonna give him the base of the 60 mLs plus the additional, yes. 110, I agree with you. So if we know that 110 is his maintenance rate, what is 1.5 times his maintenance rate? $165, I agree. And what about 2 times maintenance? 220. All right, I'm proud. Y'all have mastered this. All right, so now that we know which fluids to give, why we're giving fluids, and how quickly we're giving fluids, let's briefly talk about GI decontamination. So K-exolate, lithium is a cation, and K-exolate conveniently is a cation exchange resin. So theoretically, we thought, hey, you can reduce the levels with K-exolate. But then we found out that K-exolate can cause hypokalemia. And these patients are coming in probably altered because they're toxic. And if you cause hypokalemia, you can make them even more altered, and then they can possibly aspirate, and this would be even worse. Yes?
Back to the calculation slide.
Yes, sir.
Is there this base 20 ml depletion is only for the first 10 kilograms?
Yes. So the first 10 kilos that they weigh, they're going to get 40. So if they're 20 kilos, they're going to get the first 10, which is 40, plus the next 10, which is 2 mLs an hour. So 2 times 10 is 20. So 40 plus 20 is 60. So you can think about it, for every kilo they are over 20, because we're going to be dealing with adult patients here. I don't like dealing with pediatric patients. You can just start adding 1 per kilo that they are over 20 to your maintenance dose. Does that make sense? So if they're 50 kilos, you already know that for the first 20, they're getting 40 cc's an hour. And then they're 30 kilos over that 20, because I just told you they're 50. So 30 plus 40 is 70. Does that make sense?
So you start with 20 for the first 10.
So for the first 10, it's 4 times 10, 40.
That's 40.
So if they're 9 kilos, it's 4 times 9, 36.
So where's the 20? So where you start with 20?
So for every kilo they are above 20 kilos is what I'm referring to. If you don't want to do the math for the 4 and 2.
20 milliliters, first 20 milliliters.
So we're giving them a bolus of 20 milliliters per kilo regardless. That's a bolus.
That number is not capped.
Correct. When I'm talking about the maintenance, or that 1.5 times maintenance or 2 times maintenance, I just mean what they're getting per hour, not their bolus. They're going to get a bolus unless they have some compelling reason not to, like they're a heart failure patient and we don't want to overload them. They're getting that 20 cc's per kilo. I want you guys to be able to calculate what their hourly rate is going to be.
The hourly rate is only the 421.
Correct. Yes.
I had the same kind of question. It's because, like, on the slide it's a plus. I think that's why.
Okay, I apologize if that's confusing. So let's say, back to our 70 kilo patient, they're going to get 1,400 mLs as a bolus, right? The 20 cc's per kilo bolus, plus their maintenance rate.
So why are we multiplying by 1.5 and 2?
Sometimes the team will say we want to run their fluids at 1.5 times maintenance, and that's all they're going to say to you. And you're going to have to actually do the calculation for what maintenance is and what 1.5 times maintenance and what 2 times maintenance is, depending on what their order is. Does that make sense, everybody? Okay, cool.
You need to know how to transition between like the milliliters or whatever, and like use cc's on the exam instead of like writing it out.
So 1 ml is 1 cc. I will ask you in milliliters for clarification purposes, but it's 1 cc is 1 milliliter. It's really just dependent on what you prefer to say. When we write it down, we typically write mLs because cc's is sometimes misconstrued as 2 zeros, and it gets a little bit confusing when it's written down. But 1 milliliter is equal to 1 cc. All right. So back to GI decontamination. We don't want to cause hypokalemia with the KX-late and make our patients even more altered, because then they might aspirate, and this could be worse than the initial toxicity. And then activated charcoal is another agent commonly used for GI decontamination. But again, it's not recommended. We don't know, we may not know what the time of presentation is. So did you ingest these 200 tablets of lithium this morning, or did you ingest them last night? Charcoal typically has sort of a time. We want to get the charcoal on within usually a 1 hour window. And it can also cause people to vomit. I don't know if you've seen charcoal, but it comes in a really big tube, and it's like black, thick gunk. And I don't want to taste it. I don't think these people want to taste it. And if they're already altered and we're giving them a bunch of charcoal, again, they have the possibility of aspirating, and this can be even worse. So in general, GI decontamination for lithium toxicity specifically is not recommended. But what we can do is whole bowel irrigation. Now, I mentioned earlier on the PK slide that lithium comes in multiple formulations. And this is where the sustained release and the extended release products become really important. So if you know that your patient has ingested a sustained release or an extended release product, this should be in the back of your head as a possible option. Or maybe you don't know that they ingested a sustained release or an extended release product. What happens is, and what these arrows are pointing to, is the formation of what's called a bezoar. And essentially, the tablets or the capsules or whatever they've ingested bind together, and they form this big ball that sort of makes its way through the intestinal tract. And you might take a level, and their level's looking okay, it's coming down appropriately, and then all of a sudden you take another level, and it's spiked up. And you're like, what the heck? It was coming down, I'm giving them fluids, I'm doing everything I'm supposed to, why is this level high? And that's likely because they've ingested a sustained or an extended release product, and it's formed a ball, and a piece of that bezoar has broken off and is now in their plasma, because it's a sustained release product. So if you don't know that they've ingested a sustained release product, and all of a sudden your labs are looking weird, and instead of going down consistently, they're spiking, you can make the assumption that this is likely an extended release product. So whole bowel irrigation is really invasive for the patient. It involves putting a tube down their throat, it involves putting a tube in their rectum, and we essentially force this out using a bunch of fluid, particularly polyethylene glycol, which you guys are probably most commonly familiar with, the big tubs that you give to patients who are going to get a colonoscopy when they come up to the counter. So this is really invasive. It's a lot of fluid. It's a lot of nursing and staff. Hopefully we don't have to do it. Hopefully it doesn't come to that, but it's an option for our patients. So whole bowel irrigation is an option. GI decontamination is not recommended. And then when we get to our last line, we start thinking about hemodialysis. So I told you in the PK that lithium is a small molecule, it has a small volume of distribution. It seems like an ideal candidate for hemodialysis. But hemodialysis in itself is time consuming. I mean, how many of these patients are going to present and they're like, oh yeah, by the way, I also am a renal patient, I get dialysis, here's my fistula, why don't you hook me up? We got to get lines in these patients, right? You need someone from nephrology to come down, see the patient, say, yeah, they can benefit from HD, let's put in some lines. This can take hours. Hemodialysis itself is not benign, but it's definitely an option. So what do the guidelines say in terms of hemodialysis? So the 2015 guidelines do recommend HD or ECMO, which we're not getting into ECMO, but HD for your purposes, in a patient who presents with a serum lithium level of greater than 5, or a patient who presents with a serum lithium level of greater than 4 with concomitant renal dysfunction, right? Because we know that they're not going to be eliminating that remainder as quickly as someone without renal dysfunction. But who else can we consider hemodialysis in? Right? If these patients have some sort of life-threatening dysrhythmia or they're comatose, they can't talk to us. We've tried other options like whole bowel irrigation. We've given them their fluids. They're still not responsive. This is a last line therapeutic option. So to recap lithium toxicity and the management, We want to manage their airway, their breathing, and their circulation first. Then we would like to ideally try to determine the type of toxicity. Is this acute? Is this chronic ingestion? Or is this an acute on chronic ingestion? Because this is going to give me a better idea of how to manage the patient and what kind of levels I can expect from the patient. We want to get labs to rule out other causes of this patient's presentation. Start IV fluids with a bolus and maintenance, or 1.5 times maintenance, or 2 times maintenance, whatever our team thinks is the best for this patient. And then lastly, contact the Poison Control Center. I have the number on here because this was actually a question on my NAPLEX. So remember the number, 1-800-222-1222. And this will direct you to your local Poison Control Center. Okay, we're going to start sedative hypnotics, which is a different topic entirely. I would be happy to answer any questions about lithium now, or I'd be happy to answer any questions about lithium afterwards. But yes. Acute on chronic is probably the most difficult to manage, yes, because they have high levels in their CNS and they have high levels in their periphery. Cool. All right, so let's start with sedative hypnotics. All right, we know that sedatives have anxiolytic effects, and we know that hypnotics induct and help maintain our sleep. And these agents produce dose-dependent effects, which we are going to talk about. All right, what are sedative hypnotics? There's 3 different types of sedative hypnotic classes. We're going to talk about benzodiazepines today. We're going to talk about barbiturates today. We're not going to talk about benzodiazepine receptor agonists, but I want you to know what they are, and that consists of drugs like Ambien, Lunesta, Ramelteon. Okay, they're pretty benign in the setting of an overdose, so I've elected not to talk about them with you today, but if you have any questions, I'd be happy to talk about it. So benzodiazepines are rarely fatal in overdose, and barbiturates are more fatal in overdose, and they have very toxic effects. And all of these drugs exert their effects on GABA. Now, GABA allows for an influx of chloride ions, and this causes sort of inhibitory effects on cells. Now, if you are on rotations, or if you're particularly a student on my rotation, I always ask, how do benzos work? And you always tell me they work on GABA. And if I was a layperson and I came to the counter and I was picking up my Xanax for the first time and I said, how does this work? And you told me it works on GABA, I would say, what a jerk. That doesn't mean anything to me. It works on GABA, great. I am impressed that you remember that, but what does that mean? That means nothing, right? So first we need to think about GABA as a neurotransmitter in and of itself. Is it excitatory or is it inhibitory? Inhibitory, I agree. Okay, we're making progress. So in the bottom right-hand corner, I have put this key for you because these are like really long words. I don't expect you to memorize these words. I just really want you to have an understanding of how benzodiazepines work, because it's your job to understand how benzodiazepines work. So the VLPO is the ventral lateral preoptic nucleus, and your TMN is your tuberomammillary nucleus. Your LDT is your laterodorsal tegmental. Your PPT is your pedunculopontine tegmental, and your LC is your locus coeruleus. And we're going to go through where benzodiazepines work and why they make you sleepy, because this is important. So here I'm pointing to the VLPO and the TMN. And conveniently for you guys, right underneath in parentheses, it tells you what this area releases. So the VLPO releases GABA, conveniently in parentheses right underneath it. And you just told me that GABA is inhibitory, and I agree. So if you release GABA, an inhibitory neurotransmitter, and that acts on the TMN, which releases histamine. Let's think about this. Does histamine make you tired, or does histamine make you wakeful? And the easiest way that I think you can remember it is when you take an antihistamine, you get sleepy. So histamine makes you wakeful. If you make GABA, an inhibitory neurotransmitter, act on histamine, something that keeps you awake, you're producing sleepiness or sedation. Does that make sense? It's pretty cool, right? All right, so the VLPO releases GABA. GABA acts on the TMN and decreases the release of histamine, which decreases our wakefulness. Then we have the LDT and the PPT, both of which release acetylcholine. Similar to histamine, acetylcholine produces or promotes wakefulness. So that benzodiazepine that you took is working on VLPO to release GABA, and GABA is inhibiting both the TMN histamine release and the LDT and PPT acetylcholine release, further making you more sleepy, more sedation. And lastly, we have the locus coeruleus and the raphe nuclei. The locus coeruleus releases norepinephrine, which promotes wakefulness, and the raphe nuclei releases serotonin, which promotes wakefulness. So it all stems back to the VLPO, your benzodiazepine acting there, making GABA act on these different areas of the brain. So GABA promotes sleep by inhibiting these wake-promoting centers. Does that make sense? Don't tell your patients that come up to the counter all of this, but at least have an understanding of why benzodiazepines make people drowsy, sleepy, promote sedation. Sedative hypnotics. Cool? Cool. All right, again with the PK, I know, I'm sorry, but it's a must. So our absorption and distribution is really dependent upon which benzodiazepine agent we're talking about. And these agents in and of themselves are extremely lipid soluble. And what is our brain made of? Lipids, right? So they cross into the brain very quickly and just as quickly come out of the brain. So they have a high lipid solubility, particularly midazolam, diazepam, and lorazepam is a little bit slower, but still within 5 minutes. So very high lipid solubility. And then their distribution is really specific on, do they have active metabolites? Well, we know diazepam does. We know midazolam does. Other benzodiazepine agents don't have active metabolites, so that's going to change the onset and duration of action, clearly. Patient-specific factors. How old is this patient? Is this patient old? Is their brain dry and not as lipid full as your brain's? And it's not crossing over as quickly? Maybe. Do they have impaired hepatic and renal function? That's going to play a role, particularly when we get to metabolism, which is right below there, and I say that this is hepatic metabolism. So if they have impaired liver function, then this is going to change the pharmacokinetics of the drug. Now I have 2 asterisks by hepatic metabolism, and that's because while most benzodiazepines undergo hepatic metabolism via CYP3A4 and 2C19, lorazepam, oxazepam, and temazepam actually do not. This is just for your information only. But they undergo glucuronidation. So you need to look up these things if you have any questions, because they're all different, and we don't expect you to memorize the exact hepatic metabolism of every individual drug, right? That's impossible. And then we have the propensity for drug interactions, because I just told you that the majority of them are eliminated via hepatic metabolism. Lots of drugs are eliminated via hepatic metabolism. So you have the potential for drug-drug interactions. If it's a CYP inhibitor versus a CYP inducer, is this going to increase the benzodiazepine concentration? Is this going to decrease the benzodiazepine concentration? And these are all specific to your individual patient and what they're taking and their patient-specific factors. And because of these CYP interactions, you can expect or anticipate to see adverse events and side effects. So what are these side effects? What are benzodiazepine side effects? Right? Lightheadedness, we know that. Motor incoordination and increased reaction time. Confusion, daytime sleepiness. We just belabored sleepiness, so I know you guys understand that now. And anterograde amnesia. One of my students recently said, what's the difference between anterograde amnesia and retrograde amnesia? And I was like, that's an excellent question. So I had to look it up, and I'll share with you what I found. Retrograde amnesia is when you can't remember things that happened before, right? Retro, before. Anterograde amnesia is when you cannot produce new memories. And that sounds pretty terrible. I want to produce new memories. So these are some common side effects, but let's talk about some psychological adverse events. These don't sound as fun. Hallucinations, hypomanic behavior, disinhibition reactions like hostility and rage, And these are really how your patients are going to come in. They're not going to come in because they're sleeping, right? They're going to come in because they had a problem. And they're going to present with dysphoria and irritability. They're going to be sweating. They're going to have tremors. I included ani and GAP metabolic acidosis on here for completion's sake. This is really going to be something that you see inpatient when the team is giving this patient too many benzos. And it's specifically with lorazepam, because IV lorazepam is dissolved in a diluent called propylene glycol, and this can cause a metabolic acidosis, specifically an ani and GAP metabolic acidosis. Hopefully your patients aren't obtaining IV lorazepam on the street and coming in with one, but it's on there for completion's sake. So how do we diagnose this? We talked about the PK, we talked about how benzos work, we talked about how your patients are going to present. The most important thing that we can do for these patients is get an accurate history. I can't take a serum benzodiazepine level on you. I can do a urine drug screen on you, but depending on where you work and the sensitivity of your urine drug screen, it may or may not pick up on the benzodiazepine. Typically, your lorazepam, your alprazolam, your clonazepam, which are your most abused street drugs, are not picked up on a urine drug screen. I'm not telling you this so you can go past the urine drug screen. I'm just saying this is the reality of it. And urine drug screens aren't immediate. They take a couple hours to come back. So we want to rule out other causes of altered mental status. This is very similar to lithium, right? We want to send our labs. We want to send a BMP. We want to send a CBC. Are they altered because their electrolytes are off balance for another completely unrelated reason? Are they altered because they're hypo or hyperthyroidism for a completely unrelated reason? And then our concomitant ETOH, salicylate acetaminophen, in case this was a co-ingestion, so we can treat that appropriately. We can look at a pulse ox. You know, are they hypoxic? Is this why they're altered? Or are they altered because they ingested something? And then pupil size. Pupil size is on there sort of as a rule out. Benzodiazepines aren't going to make your pupils big or small. But if someone comes in altered and you look at their pupils and they're pinpoint, well, then maybe they're altered because they took an opioid, right? Maybe it's not a benzodiazepine at all. So these are rule outs. The most important thing you can do is get an accurate patient history. A lot of times they're going to tell you, oh, I took a bunch of Xanny bars. Oh, okay. You know, so ask them. How do we manage them? Supportive care, right? They're agitated. It seems kind of counterintuitive, but because we give agitated patients benzodiazepines, right? And they've already overdosed on that, so it's something to keep in mind. Flumazenil is the quote-unquote antidote for benzodiazepine overdose. And it works as a competitive inhibitor. It's not binding to the individual benzodiazepine that this patient took. It is outcompeting the receptors in the brain with this agent that these people ingested. It's indicated if your patient has severe CNS suppression, but it also has contraindications that are important to keep in mind. If this patient has long-term benzodiazepine use, or if this patient has a seizure history, you do not want to administer flumazenil, because flumazenil will displace the benzodiazepine and cause a seizure. And then, how do you treat seizures? Oh, benzos, but you already gave them the antidote, and this is going to outcompete, so now we can't stop them from seizing. That's a problem, right? So there are specific contraindications, which I advise you to know. And the dosing, the one drug that I'm going to give you dosing for. 0.1 to 0.2 milligrams. The end. Okay? 0.1 to 0.2. You can elect to do a continuous infusion. I've never seen one done, but it's possible. If you check a drug information source, it will tell you. So I've included it on there. But I really just want to know what the bolus dose is. Cool. Done with benzos. Moving on to barbiturates. Barbiturates are old drugs. We don't come across them very often. You might see like the 80-year-old grandmother who comes in and she's like, oh, I have a phenobar prescription because I can't sleep. Okay, but we don't do that anymore. We have better agents, right? We have benzodiazepines. We have benzodiazepine receptor-like agonists like our Ambien and our Lunesta. So it's a little atypical, but they're out there, and we need to be aware of them because they do have specific indications, even though they're not great drugs because they're so toxic. So similar to lithium, our barbiturates are narrow therapeutic index drugs. All right, they're indicated for an induction of a coma. You have a patient that comes in, they're in refractory status epilepticus, we can't stop them from seizing, and we need to try to save their brain. We can induce them into a pentabar coma, sure. You're not going to see patients on the streets coming out of a pentobarb coma, right? But there are indications for these barbiturates. Like I said, your grandmother who can't sleep, maybe she's got a prescription for phenobarb, fine. And then alcohol withdrawal, it's kind of an older drug. It fell out of favor because we do have benzodiazepines. We put patients on symptom-triggered therapy, CWA therapy for alcohol withdrawal, but phenobarb is actually coming back for the treatment of alcohol withdrawal. So you'll see it sometimes. I talked to you in depth about benzodiazepine mechanism of action. I'm not going to do that with barbiturates, but I am going to say they act on GABA, okay? They increase GABA, an inhibitory neurotransmitter. But they also have a secondary mechanism of action, and that is they decrease glutamate. So is glutamate excitatory or inhibitory? Excitatory, right? So we're increasing our inhibition, and we're decreasing our excitation, and that together leads to a huge increase in CNS depression. And this is why these are dangerous drugs. They're a twofold mechanism of action, both of which depress your CNS. Cool. All right, so I mentioned earlier about, they produce dose-dependent effects, these drugs. And what I really want you to understand is drug A or drug B more reflective of a benzo or a barbiturate? So barbiturates are CNS depressants essentially until CNS activity is silenced because you're dead. Okay, they don't have a cap on them. Whereas benzodiazepines, you see that anxiolytic, that sedative effect, and then they kind of plateau or taper off. So here I have plotted two hypothetical dose response curves. So on drug A at the lower doses, you're going to have more of your sedative effects, and then you're going to have sort of your hypnotic effects, and then at higher doses, anesthesia effects, and then your seizure, coma, death, right? And then drug B, at lower doses, again, you have your calming anxiolytic effects, then you have your hypnotic effects, and then it kind of tapers off. So if you had to take a guess, is drug A a barbiturate or a benzodiazepine? I agree. Awesome. So how do we classify barbiturates? We have short-acting, ultra-short-acting, intermediate, long-acting, and underneath, in the parentheses, I've included their durations of action. So you can see that the duration of action goes anywhere between half an hour to greater than 6 hours. Now, just to give you guys some examples, you don't have to memorize this, but your ultra-short-acting drug would be like your methotrexate. Your short-acting is your pentobarbital, which is why we put these patients in pentobarbital comas. They have to be on continuous infusions, right? We can't just give them a push and walk away because it's short-acting. Then you have your intermediate acting, so your amobarbital, and then your long-acting, your phenobarbital. And this is really going to be what patients are finding on the streets and coming in with, because it's PO. So again, and very briefly, the pharmacokinetics of barbiturates. Why are the short-acting and ultra-short-acting so short-acting? It's very similar to the benzodiazepine. They are very lipid-soluble. They cross your blood-brain barrier, and they come out of your blood-brain barrier just as quickly. So they have increased lipid solubility, and this results in increased liver metabolism and greater redistribution, versus your intermediate or your longer-acting barbiturates that have enterohepatic recirculation. And I think you guys probably learned about this earlier on in your career, but just to refresh, you have a substance, it's metabolized by the liver, right? Things undergo first-pass metabolism in the liver. They're excreted into the bile, and then they get into your intestinal lumen, and this is where they're reabsorbed by enterohepatic recirculation and brought back to the liver from portal circulation, and this is why they stay in your system longer. So this is why they are longer or intermediate acting barbiturates. Now I mentioned that your patients might say, I came in and took some Xanny bars. Patients may or may not come in and tell you what they took in terms of barbiturates. So just for your information, because I thought it was interesting, I wanted to know some of the street names of barbiturates. And the first one is amobarbital, but someone might say that they took some Blue Angels. And it's because of the way it looks, apparently. I've never seen them, but this is what they tell me. Our Red Devils, they might tell you they took, is secobarbital. So if you can identify what it is from the street, you can look it up and see is this short, ultra short, intermediate, or long acting, and have a better idea of how to manage them. Then you've got your Yellow Jackets, which are your pentobarbital, and your Purple Hearts, which are going to be your most commonly seen because this is your phenobarbital. And this is just for your information, okay? Don't frantically type or anything. I'm not going to ask you. All right, what systems are barbiturates affecting? I told you have massive CNS depression. Okay, so you're depressing smooth muscle nerves and you're lowering your heart rate. It's affecting your cardiovascular system as well. You have a decreased blood pressure, you have a decreased heart rate. Barbiturates are fatal in overdose because of their effects on the pulmonary system, here in the middle. Okay, they inhibit the neurons that are responsible for your muscles to induce breathing. So they decrease your respiratory drive and they decrease your neurogenic drive by acting in the brain on the medulla. You don't have to think about breathing right now, hopefully. And when you take a bunch of barbiturates, you don't either because you stop breathing. And then lastly, our hepatic system. I said that, it affects, especially our longer and intermediate acting, right? They're involved in an enterohepatic recirculation. So we can induce liver enzymes that can potentially also affect the metabolism of co-administered drugs. So you start to see other pharmacological effects diminished or maybe enhanced depending on what they're concomitantly taking. What you can sort of expect to see in barbiturate poisoning over a course of time, it starts with slurred speech, ataxia, nystagmus, which some people say is like a ping pong. It's like the patient is literally watching a ping pong match right in front of you. Their eyes are going side to side. And that's because you have diminished brain function, right? It works in your CNS. So you have impaired speech, then it progresses to hypotension. Like I mentioned on the slide before, you have a decrease in blood pressure, a decrease in heart rate, hypothermia because you are decreasing tissue perfusion. You're reducing the patient's metabolic rate. And then finally, respiratory arrest from your depressed neurogenic and respiratory drive, coma, and death. What I read was that these are usual fatal doses. Now, I don't take barbiturates, but I did work retail a number of years ago, and I think phenobarbital comes in like 32 point something milligrams. So that's a massive amount, right? I'm talking 6 to 10 grams. These are massive amounts that these patients would be ingesting for this to be a fatal overdose. So now we've again belabored pharmacokinetics and mechanism of action and patient presentation. How do we treat these patients? There is no antidote. There's no antidote. There's no flumazenil. You can't use flumazenil for barbiturates. We need supportive measures, right? Again, we're maintaining their airway, their breathing, their circulation. We're going to give them IV fluids just because we give everyone IV fluids. We're going to rewarm them. I mentioned on the previous slide that these patients have hypothermia because we are slowing down their metabolic rate. How do we rewarm them? We put them under a blanket, right? It's like the most obvious thing that we can do. We can also use bear huggers or Arctic Sun. I don't know if you guys have ever heard of that. Usually, Arctic Sun we give to our patients who are overheated and we're trying to cool them down. But if these patients are really cold and we can use Arctic Sun to get them to a normal temperature, we can use it to warm them up. Theoretically, they're below normal temperature. So we have methods for doing this. We can give them warmed IV fluids. Right? This is the basics. We can't really do much for these patients. We can maybe do some decontamination with gastric lavage and activated charcoal, but it's typically not going to be very successful. We may or may not know the time of ingestion. And maybe some hemodialysis. So I've now come full circle, and I've put my dog on here because Ernesto just recently received a devastating diagnosis of bipolar disorder, and he is now on lithium. And I don't think that it's working for him. But he's not depressed, he's just manic. So we'll see. All right, you guys, any questions that you may or may not have on lithium, barbiturates, benzodiazepines, I'd be happy to entertain. Otherwise, here are my references. And thank you. And I'm sorry I stood in the way of your last class before finals. Oh,
They blew it.
all right.
I said to do a hello? Quick. It's very fast. So there's the service scores, the CTAR scores, the surveys. Fill them out. Dr. Patrick Bridgman, if it's excellent. Stephen Nuremberg, if it's not. Alright, so please fill those out. Be constructive. Don't be mean. Sometimes I read them out loud just to make myself feel better if they're really mean. Maybe next year if I do your class, I'll read the scores from this class. You guys are reading things, and it's kind of funny to read them out loud. If you YouTube it, you can read, watch the professors read their scores out loud. It's kind of funny. So in any event, please provide constructive feedback, or just say nice things. You can say mean things too, I don't know. I work in the emergency department, so people are sometimes very mean. In any event, thank you very much.